बड़ा अच्छा लग रहा है आज का अटेंडेंस देख के, मतलब कम ही है लेकिन बारिश के हिसाब से ठीक है। 15-20 लोग भी आ जाते हैं तो लगता है कि सीएमए में कुछ जान आ गई। और अब चूँकि टाइम बहुत हो गया, 9 o'clock हो गया है, डॉक्टर साहब को टॉक भी कितने हैं, थोड़ा 35-40 मिनट्स का है और आई होप एवरीबडी विल लाइक। नाउ आई इनवाइट आवर साइंटिफिक सेक्रेटरी डॉक्टर सिद्धांत to read his CV, today's speaker CV and continue it. Okay. Doctor prayer भूल जाते हैं।
Today's topic is an update on benign diseases of breast, which will be discussed by Dr. A.P. Gupta sir. He has been practicing in Sangh Hospital since 1990. He is a senior consultant surgeon and a laparoscopic surgeon there. He has done his MBBS and MS from SN Medical College, Agra. Sir is a well-known laparoscopic surgeon and he is a very active member of GP Association and IMA. And he promotes us also to be a very active member. He is very humble, polite and a ground to earth. With these words, I would like to invite sir to continue with the topic. Thank you.
So, हमारे सारे मित्रों, सीनियर्स और हमारे साथ के लोग सभी को मेरा अभिनंदन है. Very good morning to all of you. Today I have been given the topic to talk something about the benign disease of the breast, which is a very common problem we come across in our day-to-day clinics. So before you go to the proper disease, so we should know something about the surgical anatomy. Everybody, one of us knows that these everybody has studied and knows about the breast, but even then I want to just make your memory fresh about the surgical anatomy of the breast. The breast lies on the chest wall. Vertically it extends from the second to the sixth rib. Horizontally it extends from sternum to the anterior mid-axillary line. Breast lies over the pectoralis muscles. The breast basic unit of the mammary gland is the lobule. There are so many lobules, from 10 to 1,000 100 lobules that empty through the ductus to the dactyferous ducts, of which dactyferous ducts are the 15 to 20. You can understand well, it is being seen in the diagrams. There is the suspensory ligament of the Cooper, which support the breast more in the lower part than upper part. There is areola and then there is nipple. These are the basic structure of, you can see very well by this diagram, the breast structure, female breast anatomy. Something about the development of breast, that it develops on the chest wall. So the primitive milk stick develops in different age of the fetus, and the near term the mammary gland forms and ducts form. So the breast talk is basically, people are very apprehensive. All the patient of having any problem in the breast, they are very apprehensive about the kahin cancer to nahi ho gaya hai. So few words about the pathology. What we come across in our clinic, the cancer involves the suspensory ligament of the Cooper, that leads to the dimpling of the skin. You can see in the well diagram, this sort of patient come to us. Cancer, if involves the lactiferous ducts that push the nipple inside and leads to the retraction of the nipple, is very common identity we come across in our clinic day to day. PD orange, the skin resembles orange peel due to the blockage of the dermal lymphatics, more conspicuous sign of the malignancy. You can see very well on the photographs, it is self-explanatory. Now the benign disease of the breast is the most common cause of the breast problems, up to 30%. The breast problem, among the breast problems, 30% the problem of the benign breast diseases, benign diseases we come across. The most common symptoms, the pain, lumpiness, lump, and main aim of us to be the clinicians to exclude the malignancy, which is not very common, but of course the people are very apprehensive to exclude this disease. So the benign disease of the breast has been classified in 5 types of subgroup, like the congenital disorders, non-breast disorders, anti-disease, and pregnancy-related and miscellaneous. So about the congenital disorders, you see the hemiplegia, polymegia, mastitis of infants, diffuse hypertrophy. These are the congenital disease of the breast. The non-breast disease are like the cyst disease, the costochondritis, sebaceous cyst, and other skin problems on the breast. In the anti group of that, they have divided in the cyclic nodality and mastalgia, cyst and fibroadenoma formations. Pregnancy related, these are the galactosile and the puberal sepsis. This is the aberrations of normal development and innovation of the breast. So the pregnancy related is the galactosile and puberal sepsis, miscellaneous is ductictia, periductal mastitis, injury and inflammation. So congenital anomalies among in that group, you see the imagia, you can see the diagram, it is very clear. It is the absence of the breast in the particular site. This is the imagia, polymagia, that accessory breast. Sometimes we find, I have never find except 1 or 2 cases in my practice. This is the polymagia, accessory breast that lies in the axilla, or most common in axilla, groin and buttock and thigh also. And this functions during the lactation, you get the secretion of the milk. Then you come to know that these are the accessory breast. Mastitis of the infants is one identity which is common in the both boys and the girls. It occurs in 3rd to 4th day of the life, and drop of the colorless fluids comes once you press the nipple. After a few days, slightly milky secretions happens that we say the which milk, true mastitis is uncommon. So now another diffuse hypertrophy of the breast occurs in the puberty. It is benign virginal hypertrophy, and less often it is in the pregnancy. Rarely it is unilateral. You can see the photographs. Most time it is a diffuse hypertrophy. Atrophy is bilateral. Tremendous overgrowth may reach to the knee when the patient is sitting. This photo has been given in Love and Belly also. Due to alteration in the normal sensitivity of the breast to the estrogenic hormones. So this happens, the treatment is the reduction manoplasty. Something about the injury of the breast. The patient present to us with the hematoma or the traumatic fat necrosis. It may be acute or chronic, history of the blow or even the indirect violence and contraction of the pectoralis muscle. We can get on the history. On the examination, this sort of patient, you can see the photographs. It is the lump, it is painless, mimic a carcinoma. Then sometimes you have to go for the biopsy also. So history of trauma is not a diagnostic in this. So we have to exclude the malignancy in this case. Acute and subacute inflammation of the breast. Bacterial mastitis is the most common variety. Among the benign disease of the breast, most common variety is the bacterial mastitis. Lactational mastitis is seen far less because these days, as before, because they have the very good antibiotics and that subsided with antibiotics. Mostly the acute and subacute mastitis, the organism is Staphylococcus aureus. So in the newborn baby, there are 50% of baby having the staphylococcal cocci in the nasopharynx. So when they get the feed of a mother, so they transmit the organism like this. So how did it happens the mastitis? Lactiferous duct will first become blocked by the epithelial debris. Then stasis happens once within ampulla. Staphylococcal cocci cause clotting of the milk. Within the clot, organism multiply and that give the mastitis. So clinical feature of the bacterial mastitis, you can see by the diagram also, is very clear. Pain, fever, swelling. Once it is early, then generalized cellulitis you see, and once it got late, then fluctuation also can be seen, that is the breast abscess formations. Management of the mastitis is during cellulitic phase, we give the proper antibiotic. Most proper antibiotic is the amoxiclav, is a very good suitable antibiotic for this case. Ask the patient to feed the child from another breast. Ask the patient to give the support, breast support, local heat fomentation, analgesia, and if the antibiotic used in presence of untrained pus, the antibioma form, that is the large sterile brawny edematous swelling. In case of the pus, once it is not getting subsided by the only antibiotic, then you think of the pus. So you diagnose it either by the ultrasound, or you can diagnose yourself. You will get the fluctuation on the breast. So if you can do the small abscess, you can do the aspiration also and take out the pus and give the good antibiotic, and that may subside. But mostly, it doesn't subside. So once your fluctuation is there and you feel it is a breast abscess, one should go for the incision and drainage. That is the best treatment. Chronic inflammatory disease that follow the inadequate drainage of the pus, injudicious antibiotic treatment difficult to diagnose. When the encapsulated within the thick wall of the fibrous tissue, it cannot be distinguished from a carcinoma without histological evidence or biopsy. This is the chronic inflammatory disease. Some words about the tuberculosis. We do get very few cases of tuberculosis of the breast. It is rare, but usually it is associated with the active pulmonary tuberculosis or the tuberculosis adenitis. The clinical feature is the parasumon, multiple and chronic abscesses and sinuses, stylish bluish attenuated appearance of the surrounding skin. So straightforward you can say this is the tuberculosis of the breast. So you make the diagnosis confirm, you go for the bacteriological examination, even the histopathology, you send the fluid for the AFB, and the treatment is anti-tubercular treatment. One identity is the Mondros disease of the breast. You can see in the photographs it is nicely showing the thrombophlebitis of superficial veins of the breast and anterior chest wall or arm. So this is the Monro disease. Pathognomonic is the thrombosed subcutaneous cord usually attached to the skin. When asked the patient to raise the hand, skin over the breast is stretched and a narrow, shallow subcutaneous groove alongside the cord becomes apparent, like the string-like of appearances. So it is a Monro's disease. So differential diagnosis to be made is the lymphatic penetration from a occult carcinoma of the breast. Sometimes it look like that. So one has to be very precautious to make the diagnosis. Coincidentally coincidentally develop into malignancy also. Now, ductal ectasia and periductal mastitis is also benign disease of the breast. What is duct ectasia? Duct ectasia is dilatation of the breast ducts with periductal inflammation. Pathogenesis is obscure. More common, it is found more commonly in the smoker patients. Though of course in our India, the females are not that much fond of the smoking, but the abroad many people are the smokers. It happens more than the 40 years of the age of the woman in the perimenopausal woman. So how the duct ectasia happens, So in first stage the dilatation in one or more large lactiferous ducts, which fill with a stagnant brown or green secretion and result in discharge from multiple ducts. Irritant reaction on surrounding tissue leads to the periductal mastitis, also known as Juska disease, or even the abscess or fistula formation, fibrosis, and the slit-like nipple retraction you can see in the duct ectasia. It happens like this. So diagnosis is made by the ultrasound, multiple dilated ducts. In that case you have to rule out the cancer also. Management in case of the nipple retraction in duct ectasia, you find rule out carcinoma by mammogram and negative histopathology or of FNAC. Any suspicion remains, mass should be excised. We have a much more patient in the clinic we come across. Antibiotic to be given fluoxetine, co-amoxiclav, and surgery for the notorious difficult condition. We consist of the excision of all the major ducts. Important to shape back the nipple to ensure that the terminal ducts are removed. So I have made a small chart of the very common diseases of breast, benign disease, duct ectasia, Monro's disease, Tiss disease, and Josuka disease. Of the duct ectasia is the dilatation of the lactiferous ducts. How it looks, you can see in the diagram how it looks. It is found in the smoker group of the populations. Clinical feature is the serious greenish bloody discharge comes in duct ectasia. Treatment is the microductectomy. Monro's disease is pathology. I told you the superficial thrombophlebitis looks like this. It is not related to the smoker population of the people. Clinical feature is the painful tender cord-like vessels. Treatment is NSAID and the remove and the excision of the thrombosed vessels. In the Tiss disease is the non-mammary gland disease. So it is basically the costochondritis we come across in our clinic. This costochondritis of the second and third ribs, and of course this disease is related to the smoker populations. Mimics like the mastalgia. Patient present to us like the mastalgia. Treatment is the NSAID and tight breast support. Juska disease is nothing but it is a chronic subarrial abscess. It is very clear. In this diagram you can see this is the subareolar abscess. It is of course related to the smoker populations. The abscess forms, fistula and abscess can be there. So treatment is the debridement and antibiotics, and sometimes the excision of the fistula also we can do. Now a few words about the ND. ND is the aberrations of the normal development and the involution. The one group of the National Health Service breast screening program was made in the UK, and they have developed this thing. They are showing in this diagram. You can see the benign disease has been covered in this diagram. As you can see, the age, different age has been shown. The fibroadenoma happens more in the right from the 15 years to 40 years of the age. The breast nodality of the breast, simple cyst, and the malignancy right from 30 years to the onwards, any age can happen, you know. So this is the ND. ND, the etiology, the difference, disturbances in the breast physiology from the normality to well-defined disease process, has very little correlation between the histological appearance of the breast tissue and the symptoms. Pathologically, ND has been divided in four. One is the cyst formation, another the fibrosis, hyperplasia, and the papillomatosis. The cyst formation is inevitable and very variable in size, maybe small, maybe large. Fibrosis, that fat tissue disappears and the rare and are replaced with the dense white fibrous trabeculae. So the interstitial tissue inflated with the chronic inflammatory cells. So you get the fibrosis. Hyperplasia in epithelium of the ducts and acini with or without atypia. Papillomatosis is so extensive hyperplasia that results in the papillomatis overgrowth within the ducts. Clinical feature of ND, area of the lumpiness can be cyst or fibroadenoma. Lumpiness may be bilateral, commonly in upper outer quadrant, which is the common lesion of the breast you find in the breast examination. Changes may be cyclic. Lumpiness and tenderness increase during the menstruation. Non-cyclic mastalgia is more common in the perimenopausal and postmenopausal woman, may be associated with ND on periductal mastitis, should be distinguished from the referred pain like the musculoskeletal pain. Only one thing I want to impress upon you, that only 5% of the breast cancer exhibit pain at a presentation. So we should be very aware. Any patient comes with the breast problems and it is painful, so one should be happy, patient and doctors. Once it is the painless, no pain, and there is the lumpy there, this is the very anxious and very apprehensive. We have to diagnose it, may be malignancy. So this is the very good criteria. It is written in the book that only 5% of breast cancer exhibit pain at the presentation. Treatment of the lumpy breast is not much. Many patients come of the lumpy breast. अब हमारा बहुत बड़ा ये समस्या है. So you have to re-ensure at the first review at different points of the menstrual cycle after 6 weeks. Patient will be unnecessary, should not be, patient are very anxious, should not submit it to multiple random biopsies for that. This is the reassurance to the patient. This is not a very big disease. It reduces, it comes to normal after some time. So we suggest the patient like this. Mastalgia is the commonest breast problem we come across. This is the commonest breast problem, poorly understood. Most poorly understood. The reason of the mastalgia is very poorly understood. A lot of patient comes, सब दवा खाया, ठीक हो गया, फिर हो गया, कब तक दवाई खाना है. So these are the problems. 90% cases are benign. And there was one study that said that the fibroadenoma proportion of the benign breast disease in India is falling dramatically as painful nodality is getting the prominence. This sort of patient we are come across. Treatment of mastalgia, initial form, reassurance that symptoms are not associated with cancer. That is a very good message to the patient. One has to make very clear that देखो ये cancer नहीं है mastalgia. Of course, सब exclude करने के बाद, then that the anxiety of the patient decreases. So make them understand this is real. This is a symptom to be actively cooperating. Appropriate feeding and supporting bra should be worn throughout the day. A soft bra should be worn at the night. Avoid caffeine. For cyclic mastalgia, Isle of evening primrose in adequate dosage over 3 months will help in more than half of these women, especially more than 40 years of age. So here also you cannot make the promise the patient जो तुम्हारा ठीक ही हो जाएगा. It is written in the literature that only the 50% of the women they get the relief from that. Rest 50% they don't get relief even with the this Agrawal or evening primordial. For those with the intractable symptoms, some patients have the intractable, very pain, then in that case we start danazole, danazole we start 100 milligram per day and increases the dose according to the symptoms of the patient. We can start the bromocriptine also, a prolactin inhibitor. Rarely we give the treatment of tamoxifen LHRH agonist. Non-cyclic mastilia is just like a TIS disease. It is known as the costochondritis. It happens in the second to third ribs of the chest wall. Treatment is the intra-regional triamcinolone. It is one sort of steroid. Pericort के नाम से आता है. We inject with the 2% Jalocan to the particular site and the pain relieves. Cyclic and non-cyclic mastalgia. Cyclic is 2 weeks before the menses. Cyclic mastalgia happens 2 weeks before the menses and diminishes with onset of the menses. Term cyclic profound mastalgia or severe painful nodality use pain persists more than a week in the cycle. So this is known as the cyclic profound mastalgia. Excessive pain in the premenstrual period is bilateral, diffuse, as well with the diffuse nodality, heaviness or feeling of the increase of the size of the breast 50%. Even the patient says बहुत बड़ा महसूस करते हैं. It happens in the young and the middle age. Increased estrogen response to the breast. This is the reason. Non-cyclic mastalgia is more common in the perimenopausal and most postmenopausal one. May be associated with the referred pain from the chest wall. It may be unilateral, may be bilateral. So one study has been made of the 232 prospective documented mastalgia patients. It is found in that the cyclic cyclic is 40%, non-cyclic is 27%. So more cases of the cyclic mastalgia we get in our clinic. Non-cyclic is 27%, TIS disease is the 11%, trauma in 8%, sclerosing stenosis 4.5%, cancer we get in only 5%. This sort of mastalgia cases. So very rare chances of the cancer. Musculoskeletal disease is the 9%. This is the one study, a study of the myalgia patient 232 number, and they have described like this. The concept of the breast pain. Increased breast volume is the cause of that causes the pressure on the pain nerve endings. Breast pain or discomfort that leads to the mastalgia. Severe lasts more than a week, disturbing activity of the day-to-day life, that is pathological. Concept of the breast nodality is initially uniform growth of the cells throughout the gland. That the later one, some cells becomes more hyper-responsive, very target organ responsive to hormones, that leads to the tender nodules. At one month visit, check the pain chart. If the pain score is more than 1 week, pain interfering with the activities of daily life, then they start the systemic therapy. Systemic therapy is the drugs, the evening primordial, ormiloxifene, tamoxifen, danazole, bromocriptine. Drug therapy for 3 months to be given initially, and ask the patient to give the diclofenac gel also. They can do the massage on that, that also get some relief from that. Evening primordial, you can see the rich in the omega fatty acids. This inhibits the prostaglandin that causes the breast pain, that decreases the breast pain, side effects are nausea, diarrhea and headache. The cost therapy is not very high. Role of the ormiloxifene, Novex, that is in regression of the mastalgia and the fibroadenoma. This drug is developed in India and is discovered by the Drug Research Institute of Lucknow. This is the Novex. So we give in the fibroadenoma to decrease the size of fibroadenoma. Now one identity, the nipple discharge. We were very anxious about this nipple discharge of इसमें ये आता है, खून आता है, पानी आता है. This lot of things, So the definition of this nipple discharge, what you say, the definition is a spontaneous efflux of fluid from nipple apart from the histological function of puparium and lactations. So this is the nipple discharge. We are more anxious about, the patients are more anxious about this. So there is the one small chart, the type of the nipple discharge, main cause and the less common cause. Of course, if the bloody discharge, it happens in the hyperplastic lesions, duct ectasia, pregnancy, serous discharge, the same way, watery also in the same way, colored discharge, duct ectasia and cyst. The milk is of course the physiology, that is not a discharge, that is a normal phenomena. So hyperplastic lesions, hyperplasia, papilloma, carcinoma in situ, invasive ductal carcinoma. So it happens in these cases, we have the abnormal nipple discharge. Then we have to assess the patient, assessment by history, examination, investigation, ultrasound, mammography, ductography. Management, you extrude. First thing is to extrude the lump. If there is a nipple discharge, you extrude the lump. If the lump is there, then the diagnosis goes in another side. Milk discharge, extrude mechanical stimulation, prolactinoma. If it is a more less than the 40 years old woman, the water, serous and serous sanguineous discharge, persistent and localized to the one duct, then you go for the microdectomy, the operation. If it is not localized, nipple discharge is not localized, then observe every 4 months of the 1 year in suspicion of malignancy. Diagnostic tool as the mammogram. If no abnormality is detected on imaging, then if discharge is confined to single duct, then you go for the microdectomy. If discharge cannot be localized, then segmental peripheral duct dissection to be performed. Management, medical management, unlikely to give long-term control. Discharge, nipple discharge का जो है, antibiotic to be given. Indication of surgery in the nipple discharge is only if it is very copious, bloody, it is the nipple inversion, subdural abscess, fistula, eczema, recurrence after previous surgery, then you go for surgery in the case of the nipple discharge. Few words about the breast cyst. You will come across some usually in the last decade of the reproductive life. So as a result of non-integrated involution of the stroma and epithelium, diagnosis to be made by the ultrasound or by the aspiration. You can see in the ultrasound how it looks like, the cyst, the clear fluid, this hypoechoic fluid in the ultrasound picture. So type of cyst in the breast, the atypical cyst, fibrous cyst, fat cyst, solitary cyst and multilocular cyst. So how it happens cyst, the solitary cyst or the small collection can be aspirated. The small 30% will recur and require the re-aspiration. If blood stain or residual lump cyst forms repeatedly, then you have to go for the core biopsy or local excision for the histopathology. Now fibroadenoma is the one thing. Fibroadenoma is the most common cause of breast lump. Any lump patient comes that हमको साहब गांठ हो गया है, तो first diagnosis to be the fibroadenoma. So it is written in the book, the most common cause of breast lump is the fibroadenoma. It happens in the age group of 15 to 25 years. Usually in the fully developed breast, you see the fibroadenoma. Etiogenesis arises from the hyperplasia of a single lobule, grows up to 2 to 3 centimeter in size. You can see in the photograph different type of fibroadenoma it is being here. So surrounded by the well-marked capsule and thus can be enucleated. So the fibroadenoma is always it has the well-marked capsule so that you can enucleate nicely in the operations. So, but it is not the vague nodules, many nodules. So that goes in favor of the fibroadenosis. That is not the need to do the surgery for that case. So I am talking about the fibroadenoma. Usually does not require excision unless associated with the suspicious cytology or become very large and patient express their desire to be removed. Some patient छोटा गांठ है, कैंसर नहीं है तो छोड़ देते हैं, ठीक है साहब, वो ऑब्जर्वेशन में रखिए, लेकिन बहुत कहते नहीं साहब हमको इसको निकालना है, मुझे बहुत डर लगता है, तो उसको निकाल देना चाहिए. तो the fibroadenoma is very large. One identity is the giant fibroadenoma, more than 5 centimeter diameter, rapidly growing, that is the giant fibroadenoma. So you see the few photographs I have mentioned in the slide is the mammogram. How does the fibroadenoma looks like, the whitish structure in the breast. This is another specimen. You can see in the clinic, this is the lump here, the excised specimen. Clinical feature of fibroadenoma, it is a firm, mobile lump, painless. And one thing is that the only 10% cases you get the multiple fibroadenoma. कहते साहब बहुत सारा गांठ है मेरे ब्रेस्ट में जो है, देखिए साहब 2 जगह है, 3 जगह, यहाँ भी है, वहाँ भी है, तो देखो तो fibroadenoma is only in 10% cases you have multiple. Otherwise you have the solitary swelling in the breast, that is a fibroadenoma. Hardly it is a multiple in number. लेकिन पेशेंट कहता है साहब हमारे कई जगह पर आप देखिए, इसको एग्जामिन करिए. So diagnosis is made by the ultrasound, mammogram and the MRI scan also. So how does it look in the ultrasound? You can see the ultrasound figure, this one. This is the mammography. This is the MRI scan. How it looks, it's written there. It's shown there. Type is based on the histopathology. What are the types? Is the pericanacular and the intracanacular. Pericanacular, it seems to be hard lump, and the pericanacular is less hard. Management indication of surgery cosmetically. If it is a painful, rapid increase in the size, family history of the breast cancer, a giant fibroadenoma. These are the indication for surgery of the fibroadenoma. Scarless fibroadenoma surgery also being done by the radio frequency ablation for the cosmetic purpose. And mammotome has also come. The mammotome, you do the vacuum assisted biopsy system, we can remove the fibroadenoma. So this is the excised specimen of fibroadenoma. दूर से दिख जाता है इधर how it is, looks the fibroadenoma. Now one identity the adolescent hypertrophy. Adolescent hypertrophy, you will come across some patient in the clinic. Gross stromal hyperplasia at the time of the breast development. Etiology unknown, a little bit is known about the control of the breast stroma. However, the dinazole have the beneficial effect for the adolescent hypertrophy. we come across many patients of nipple inversion in our clinic. So what is nipple inversion? Nipple inversion, the failure or development of the major duct, abrasion of development of terminal ducts, preventing normal protrusion of the ducts and areola. Nipple inversion predisposes to the terminal duct obstruction that can lead to the duct fistula also. Now this phyllodes tumor, I want to talk something about the phyllodes tumor. Previously it was known as the serocystic disease of the body or cystosarcoma phyllodes. Usually occurs in the woman more than the 40 years of the age, but it is not certain. It occurs in the young people also. Presentation is large, sometimes massive tumor, unevenly bossulated surface you can see on this diagram. The occasionally ulceration overlying skin due to the pressure necrosis. But despite of all these things, this is the only large tumor in the breast which is always mobile. So this is a very diagnostic thing. Very large tumor having the ulcers on the surface. दूर से देख के लगता है तो कैंसर ही होगा. लेकिन once you examine and you see it is a very mobile, there is no lymph node, then it is the phyllodes tumor that can be diagnosed. You see few photographs of the phyllodes tumor, excised specimen. So histology, the no malignant potential resembling of fibroadenoma. Others have the higher mitotic index which are histologically worrying. Management is lumpectomy, wide local excision. But in this fibroadenoma, if it recurs time to time, then you have to go for the simple mastectomy also for the recurrence and very large tumor and it is malignance. I have come across 2-3 cases have giant fibroadenoma in our clinic. उसको निकाल दिया, कुछ 1 साल 2 साल बाद फिर लेके चले आ रहे हैं साहब, फिर हो गया जो है, आपने कैसे ऑपरेशन किया है, फिर हो गया जो है, उसको फिर निकाल दिया, फिर कुछ साल के बाद ऐसे भी फॉलोअप में मेरे 1-2 पेशेंट हैं, उनको समझा अल्टीमेटली उसको सिंपल मैस्टेक्टमी करना पड़ा, उसको निकालना पड़ा जो. सो दिस डिजीज लाइक दिस, बट थैंक्स गॉड इज नॉट मैलिग्नेंसी. This chart I escape, investigation breast lump, the cystic and solid. Once it is the cystic, disappears, lump disappears, fluid, clear fluid comes, then discharge the patient. Cystic lesion. If it is cystic lesion, residual thickening there, blood stain fluid comes, then investigate and go for the core biopsy. If the lump is solid and benign, often you should excise and it will be all right. Solid atypical lump, you go for the core biopsy. Solid malignant lump, it is only just say is a very short table I have made. A take home message is the proper palpation of the breast. That is very important. Ma'am, this is the proper palpation of the breast. Always palpate for axillary lymph nodes. Avoid maximum use of antibiotics for long time to prevent the occurrence of antibioma. And I request my gynecologist and the physician friends always to take the help from your surgeons colleagues. Thank you very much.